Good morning, Holly, and thanks for being here with me today on this peer-to-peer video series.
Oh, it's a pleasure.
Yeah, yeah. Would you care to take a moment and introduce yourself to people?
Yeah, so my name's Holly Maya Greenwood. I am a speech and language therapist and orofacial myofunctional therapist, so dual qualified, and I'm working in Hexham, Northumberland, which is the northeast of the UK, northeast England, UK.
Okay, great. So you took the seminar last December 2024 in Edinburgh, correct?
Yeah.
Yeah, I probably said that improperly. Edinburgh. There we go. But how? So what intrigued you? What caused you to want to take the class? May I ask?
Yeah. So I have been working many years as a speech and language therapist, and I had recently added to my specialism orofacial myofunctional therapy. And I'd actually had your course recommended by some colleagues who weren't speech and language therapists, which I thought was interesting because of the voice and swallowing element, the one that I came on. And yes, I was really keen to increase my skills in the hands-on element because I think touch is a really important part of the way that we connect with people. That's very intuitive to me. I've done trained in certain approaches that use touch as a kind of prompt, like a tactile, kinesthetic prompt on somebody, but it was less the element of it that was more biopsychosocial, like how you bring in, wasn't really included in the way I would like in that. And I wanted to be able to incorporate that, especially into the myofunctional therapy aspect of what I was
Yeah,
doing.
yeah. And to me, I'm so glad you used the word touch too, because I talk about touch versus manual therapy and that overlap that a lot of people don't really see, that how touch might be nearly equally or equally impactful as a sustained sort of manual therapy or myofascial release sort of touch. And all those other aspects of the behavioral concepts, et cetera, that are involved with touch. And so it's really good for you to hear, or for me to hear that from you. So, primary patient populations.
Sorry, what are my patient populations, did you say?
Yeah, yeah.
Uh, yeah, so mixture of children and adults, mainly now, actually, mainly they would come actually wanting orofacial myofunctional therapy. So they would come with difficulties with breathing and usually speech in some form, um, even if it wouldn't go into a categorizable disorder or condition, they would usually have some difficulty with speech. Often I would see adults who struggle with communication confidence, so that's another strand. Um, and also then children who aren't developing in the expected way. Often there'll be a breathing and oral posture element to that with the orofacial myofunctional specialism now. Voice as well. So, um, yeah, dysphonia, patients who are getting tired with their voice or have often, because I'm not in the NHS, so in the UK we'd need, um, it's a private practice, so I wouldn't have the kind of instrumental assessment that happens in the NHS, which means that everyone who I see would usually go in the category of functional or medically unexplained symptoms for their condition, um, rather than having a like being in the kind of clinical voice that you would more
Sure,
see in a hospital.
sure. So can you know take me back to December when you left the class? How was it to begin using touch manual therapy, possibly in ways where you hadn't previously? Now I'm making some assumptions here because I don't know that. But was it awkward? Was it difficult for you and maybe for the patients you had been already seeing to begin using a new modality, if you will?
No, for me, no, it was felt very intuitive and natural to me personally. And I actually felt like I had more almost like permission or confidence to spend more time doing that. rather than like maybe a quick little palpation that I might be doing before. Um, and also because I mentioned the methods where I would have been using touch, but it would be as a kind of guide for a motor program sort of aim. That was very quick. It would be like, oh, almost like trying to catch the exact right moment and guide the system and get the touch in the right place at the right time. And it was, but this was the newness of this was more to have more time with it and to trust more in all the many mechanisms that would be working through, right? And or having some benefit through. And to be able to kind of spend more time really communicating and getting feedback from the person, which is,
Yeah.
was more useful in that new way.
Oh, that's great to hear. Yeah. You know, having taken the class so recently, we the tongue, all the tongue work we're doing, not only the tongue stretches, that manual therapy piece, but that crossover into the exercise, into the sensory awareness, building motor control. I was really well deep into it in December. How did you find that in terms? I'm curious, especially with your myofunctional patients, right? Because
Mm.
it's a different style of touch than you might use with myofunctional. Do you think it blended well?
Yeah, yeah. Well, I feel like I'm only scratching the surface of what's possible with that. Um, oh yeah, yeah. I mean, when you ask me about examples, I found that I'll give you them. But in terms of how I found it, blending, yeah, really well. I think with the right setup, so that's what helped is that I'm working in a clinic that is set up for body work. So there's kind of they had chairs and massage tables and ways that I could say, right now we might move into doing this. But I found that it's added a massive kind of a whole sphere of how we can work because a lot of my functional therapy would traditionally without the manual therapy element would be here you go, try this exercise, try and imitate what I'm doing,
Hmm.
or hear my verbal feedback on that and try and adjust it. But for some people that's fine. A lot of people they can't feel it. It's like sometimes I've had people who can't imitate an action like that, or they can't find it in the exact place. And when we've added even not even the full the tongue stretching and the bits you're asking about, but even just a stretch on the outside, they've been able to get the exercise that I'm trying to get um, when we couldn't before. And that in the past, I might have concluded, oh, well, there's a tongue restriction, for example, there's restrictions in their structure
Hmm.
that mean you just can't do that, where it's taught me that I can't conclude that
Yeah. Yeah.
as quickly as I might have.
Yeah.
That answer your question, because maybe you were asking more about the tongue
No, no,
stretch.
no, no, it does. It does. No, I'm just looking for your feedback, and that was really, really well put. You know, that concepts, the concepts of using touch resistance, manual resistance as an exercise, right? I know that I talk in the class about the difference between traditional weakness, where we need to gain strength over time by actually fatiguing a muscle, letting it rest, and then, recover, and then we do it again. Classic muscle building, which can be part of, oral motor disorders, tongue weakness, etc. But I also think there's a whole nother aspect to strength, weakness, exercises that kind of goes unnoticed. That concept of if the person doesn't have the knowledge, the ability, the awareness of something, then strength doesn't manifest. Functional strength doesn't manifest. But what
Mm.
I'm just continually amazed as I not only teach this work in each class, but here with my patients, that sometimes just having a little bit of sensory input, tongue or other place in the body, it creates a near instantaneous change in motor output, which is reflected as a gain in functional strength, but it doesn't really fall into that category of, you were weak and now you're strong, right? Did
Yeah.
you find that a little confusing at all, or were you okay with all that?
No, that's something that I already had in my concept. Like for example, if you go to the dentist, if I go to the dentist and they inject me, hopefully they don't have to, but if they inject me with the anesthetic, they're targeting sensation, and then my movement's gone all over the place. I haven't got the same feedback loop. So that sensory element makes sense to me. But I think what I've more used it with, like trying to find a motor output maybe that's new, like a new motor program, you could call it. But I think the bit that I was saying, oh, I've just only scratched the surface with, especially is, well, then once, if it's not so much you can't find it, let's help you to find it using the sensory way in. But then also then, well, now you've got something to resist in a different way, more like building the tone and doing
Yeah.
more of a like reps type thing.
Yeah.
But I have found it more useful so far to get to a place when I'm with the person in the session, and then they can find it and they can know, oh right, well if I actually do this, or I could do this, or I could replicate that, or I could do this stretch first, or I could do this first, then I'm more likely to actually get the exercise. And then they come back the next time and they've done the resistance and the reps bit themselves, and they've come and said, oh well, now I can do it. And actually I have to say I've had quite a few where they've said, oh, I've been really busy, haven't really done it, but then they can still maintain.
Yeah.
It's
Yeah.
like it's improved anyway. And like, oh right, well you clearly didn't need to practice as much as I
Yeah.
suggested you do.
I love that you just said that, Holly, because I think that it's so embedded in our therapeutic brains that they need to do their homework, they need repetition, they need motor learning, and they do need all those things many times. But I do think there's aspects of it that sometimes we wake that piece up and it's like, oh, I'm going to use this from now on instead of I need to continue to repeat the repetitive aspect of it. Not to say that that's not helpful, right? But some of this, you give them that awareness and then they begin to use it immediately and they don't lose it.
That's
Yeah.
the dream.
Yeah, it is. It is. I'm going to put you on the spot here because this isn't in my list of questions, as well as I'm putting myself in a vulnerable position too, depending on your answer. Do you feel that in the class that the work that I taught, the way I taught it, was supported by evidence?
Yeah, I do.
Good. I'm kidding. You can keep going. Yeah, I'm glad to hear that. Yeah, I didn't pre-warn you for that question. It's a question a lot of people have. Do you have evidence to support this work? And we do need that. I think that there is a fair amount of evidence for touch manual therapy, whatever you want to call it, in all these different, treatment disorders and patient profiles for the speech pathologist. I just think they're sort of buried in other literature or in literature that maybe isn't common domain for a lot of speech pathologists.
Yeah, and I guess what's something I remembered from your initial intro bit to your in-person
Oh
session
yeah,
was you saying something about there's certain people who are happy on the edges of a field, or being on the cutting edge of it in that sense, or being on in the kind of fringe of it. And I think I definitely resonated as one of those people, and somebody who is always saying, well, why aren't we looking to the literature from complementary therapies, or like arts therapies, or like other fields, even just like within the allied health professions, physio to SALT, or OT to speech and language. Like we don't do that enough. We have our own, often their own fields that we kind of would normally see as the evidence base. So yes, and what drew me to your work, and especially what's drawn me to want to continue with it, is because of what you bring in terms of linking to evidence, but also in a way that's kind of open and always asking that question: is it, or
yeah,
is it
yeah,
not? What, there's new evidence, or how do we shift what we're doing? How do we look? How do we incorporate the evidence and take that as very, very high priority in what we're
yeah,
doing as
yeah,
an ethical responsibility, and how do we keep asking questions within it?
yeah.
That's the
Well,
long answer.
good, good.
Yeah.
Well, I'm glad there was a positive response there because yeah, that was unplanned. How about advice? Might you
Yeah.
have, you're relatively new to this work, but a couple months now. Do you have advice for someone who either is already taken the class and is looking for a little bit of direction, or maybe somebody who is considering the class based on your experiences? Any advice or tips?
Well, I was thinking more in terms of someone who's just taken it and now is like oh, what the hell do I do now?
Mm,
I was confident in a room full of people talking about it and trying it out together, but now it's an actual client, patient, and it's my setting, and I'm going to do it. I would say that it's normal, and I definitely experienced this. I didn't mention this before when you asked me. I said it felt intuitive and natural, but I would say it's normal to also feel like a kind of doubt because the techniques are very gentle, I would describe, and simple in that's how I would describe it, how they feel when I'm applying them. And it's normal to feel doubt about whether you're doing anything at all.
yeah,
And I've definitely drawn on remembering like your voice saying that at some point in the seminar of sometimes I'm just thinking, have I actually done anything there or was have I actually added anything there? And that was really helpful for you to voice that vulnerability that's come up for you or comes up for you sometimes. And then contrasting that with a patient feeding back a big change. Um, and that's the experience I've had of thinking, am I really offering, something valuable, questioning like, am I really doing anything? Am I really affecting anything? This is so gentle or so simple, or I'm sticking with this. I'm not doing loads of fancy techniques. What it feels like in terms of like moving through them quickly or doing what feels like loads of different busy things in a chunk of time. But then
yeah,
that's like trusting in that aspect of it and that it does transform. So then it can transform things within the person's system, even if it doesn't feel like really obvious how.
yeah, yeah. Because I know that historically, manual that's applied to voice and swallowing, et cetera, is a very mechanistic based model. You need to identify the muscle, then you need to find origin insertion, then you need to figure out the proper way to singularly treat that muscle. And that work works. It's been in the literature for decades now. But I say frequently this annoying statement that I can't treat the digastric without a scalpel, right? In isolation, knowing that I'm singularly affecting that. When we think we're doing something with the digastric, for instance, we still have, sensory input, which causes behavioral blocks or, expectations, et cetera. There's so many different factors at play. And I know a lot of people find my work a bit ambiguous. They're looking for more of a roadmap or a protocol. And protocols have value, but you kind of lose the patient, the N of one in that experience if you're simply applying a protocol without modifying it for the person in front of you. And I think that's what I'm trying to promote that, yeah, we can work from protocols, or you can even work from that muscle perspective, but realize you're doing so much more with that human being than just affecting that muscle. So, yeah, I'm sort of a fuzzy logic approach versus that mechanistic, mechanical approach to car repair, that sort of thing. Manual therapy is often compared in that way that people see it as, well, you've got something out of balance. We need to get it back into balance like a mechanic will do. And, those are nice sort of concepts, abstract concepts, but we're not cars. We're human beings. And I just think it takes a lot more nuance to be able to affect a person versus an automobile. So sorry, I went on a little bit there. Um, Anything
Yeah.
else? Oh, go ahead.
No, just agreeing.
Yeah. Anything else you want to share about the experience of now you're kind of using this new tool, this new way that Holly looks at her patients? How does that feel to you?
Yeah, yeah, really beautiful, really exciting. Like I love feeling that whole part of my practice can have so much potential to develop because I've
Mm,
already seen it work, already really felt like I can do it. I felt like I can do this and I'm doing it and it's gorgeous. And now I can have like the rest of my career to develop it. And it's yeah, it feels like full of possibility. Like I've we've decided in a new clinic that we're setting up in Hexham in Northumberland to have a whole strand of the work be manual therapy, and that I'm working with a massage therapist, so a practitioner whose background is in complementary health and massage, to develop that side of things and to use your approach for that. So I'm feeling, yeah, I'm feeling really grateful, feeling really grateful to stumbled across you and your work.
Yeah. Well, thank you. Thank you. I think that's a perfect place to end our conversation here in this peer-to-peer series. Holly, I'm grateful to you for agreeing to share your story with others because I think it's helpful when you're kind of lost in the weeds with this different language and touch and everything to hear how others have kind of navigated those waters. So thanks so much for joining me here.
So welcome.
Okay, great.